I was wondering what simulation training benefits there are for rural students particularly.
Lots of benefits for simulation learners in rural locations, be they qualified clinicians or be they undergraduate students, graduate entry students as well, because simulation pretty much involves that just-in-time learning. It provides an opportunity, as it does for city-based students as well, but often in rural locations, students are exposed to a wider range of patient presenting issues that rather than just being in orthopedics or just being in endocrinology, they've got a much wider spread. And so simulation can enable students to rehearse just in time the sorts of procedural or physical examination or communication skills that would be required relevant to that patient. And if they're not rehearsed prior to working with the patient, the student might be observing an experienced clinician doing whatever's required for the patient. Then they can go and rehearse that procedure themselves without consequence to patients. So it's a patient-safe environment that they can practice in. We find that when students are able to practice in simulation prior to working in real settings, they're more confident to engage in learning activities in that same vein. So in many respects, it helps them to optimize the learning from their clinical activity.
What are the benefits of using a real human who's not actually a patient?
I see simulated patients as proxies for real patients.
Right.
And so real patients actually traditionally have been very passive contributors to health professionals' education.
Okay.
They have stuff done to them. Simulated patients enable well people to engage with learners in a way that enables feedback to be offered to the learner, and I use learners as qualified clinician or undergraduate student, that enables them to receive feedback in a way that there's no longer the kind of power differential between a patient receiving a service and care with a clinician provider. Now, there's still a power relationship, but it's not that one.
Yeah.
And I think that that's really important. Cate, it can go something like, okay, I'll pretend that you've been the student. So, Cate, thanks for coming and talking to me in that scenario. You come across as being a really nice and sincere person, but there was something about the way that you said to me that must be difficult. That it was as though it was empathy by numbers. I didn't feel as though it was real. So now I'll step out of role. So that sort of feedback, rarely would you get that from a real patient. So simulated patients, when they're well trained, are provided with the language to say things like, I noticed at the beginning of the consultation, you asked me some very closed-ended questions when I had a big story to tell.
Yeah.
Whereas most patients, they tend not to think about question structures or transitional statements, and so that's the difference.
There are layers of simulation, aren't there?
Cate, you make a very good point. Simulation is often thought about as one thing, but actually there are many modalities. Guy, we've spoken with you about task trainers, so that some of them are simple benchtop task trainers, learning to suture on a suture pad. Then you have more sophisticated, the laparoscopic simulators, simulated patients, patients, there are virtual patients, then there's that whole area of serious gaming, which is again another particular type of simulation which is gaining prominence within our healthcare simulation world. And then we produce, for example, something that Guy and I both do is whole operating theatre simulations,
Right.
so that we're able to address team-based issues of communication. So pretty much anything that you want to do in a real clinical setting, you can simulate in either we call them in situ simulations, so we'll go into real clinical settings and run them there, or we'll take people off-site and reproduce the encounter in a similar environment to that which it would be expected to be implemented in.
Right. Are there any situations for which simulation is just not suited?
I'm going to say no with a rider, in that it depends what the purpose is. Whether it for learning, I think you can pretty much learn anything in simulation.
Right.
I'm not suggesting that you can replace learning in real clinical settings with simulation.
Right.
But I actually can't think of much that you couldn't do in simulation. But simulation is only a method. It must not fully replace. It can supplement and orient and frame, prepare learners for working, for learning and working in real clinical settings. But I think that there's an ideal is to be able to move between real and clinical environments back and forth, and that's for all levels of healthcare providers, not just trainees.
How did you get into simulation? Was it something that always intrigued you in your medical career, or?
The entry point for me was I was living in Hong Kong, and I got a job to teach sociology in the medical school, and part of the sociology team we taught clinical communication. In those days it was just patient-centered communication.
Right.
It's a much more expansive term, clinical communication, and it was really we used role play and then introduced simulated patient methodology, and that's how 30 years later, being all over the place, and I mean that working across modalities in simulation, which has been really exciting. And I guess one of the fascinating shifts for me in the last, I guess about 5 years, has been the opportunity for me to work much more across modalities in healthcare simulation. Mm-hmm. There was once a time where the kind of Guy Maddens of this world would work with laparoscopic simulators and whole procedure simulators, but never have a simulated patient involved. The anaesthetists would only have mannequin-based sims. But actually, the advent of what was a Health Workforce Australia-funded initiative, the NetSim program, which was designed to develop the clinicians who teach using simulation. It was a professional development opportunity for them. Right. That program actually has one of the unexpected outcomes. It's broken down barriers between those kind of silos of simulation practitioners. And I've actually learned that there are many points of intersection in our practices that have informed each other. It's been a very positive outcome.
Cool. Thank you for your time today. I know you're really busy, so I really appreciate the time you've taken to talk to me.
Pleasure.